first like to thank Simon and Yuval for inviting me today to speak. This is my first Cogent meeting, and I've got to say I've been very impressed with the presentations I've seen, the quality of the science, and it's also a real pleasure to be around so many like-minded individuals who share the goal of moving our field forward as much as possible. We may not agree on everything, but I think at the end of the day we have the same goals in mind. My disclosure, as they mentioned, is I'm a shareholder in Ovation Fertility, which is a group of IVF laboratories in the U.S., of which my laboratory is a member. I guess full disclosure, I am not a molecular biologist or a professional speaker, so I suggest you adjust your expectations accordingly. What I am is a clinician. I've spent the last 30 years, 100% of my time treating patients. And I first became intrigued by the concept of what was called PGD at the time, back at the World Congress meeting in Sydney in 1999, listening to Alan and Mark Hughes talk about it, and it just fascinated me. It seemed like this was the obvious thing that we should strive for if we could actually do it. And so I spent the next several years in our laboratory trying to work towards that goal. This is a timeline of what we did. So it was really 12 years until we performed our first successful PGS case, PGTA case. At that time, we were biopsying embryos on day 5 and then turning around the results in 24 hours and transferring them fresh on day 6 after a raised CGH. But after about 6 months or so of this, and this data I'll show you in a little bit, we started to see that the results that came from the patients where we froze all the embryos really outperformed those where we were transferring fresh embryos. And remember, back in those days, it certainly wasn't commonplace to concentrate on frozen embryo transfers. Everybody thought that fresh transfers were better, and so that's what most of us did. And I spent a lot of sleepless nights looking at our data and trying to realize that, in fact, frozen embryo transfers were better. And so I finally made the decision in April to just give up the fresh transfers. And from then on, we've just done frozen transfers. This worked so well, and you'll see from our data that we felt so confident that we'd hit onto something that we, a few months later, decided to apply it to all of our patients. And so most of the data that I'm going to talk to you today is data that stems from 2012. Later that year, we made the decision to move to single embryo transfer exclusively. We were transferring 2 embryos, even though they were euploid at the beginning, especially in the older patients over 40. I was just afraid at the time. Again, in the US, single embryo transfer wasn't done that much in those days, and I was afraid we were going to suffer. Our pregnancy rates would suffer if we simply transferred 1. So we were transferring 2 in some of the older patients, but what we found was we had about a 65% twin rate when we did that. And obviously one of the goals of this was to avoid multiple pregnancies at all costs. And so at that point, and from then on, have simply performed single euploid embryo transfers for all of our patients. The only technical change occurred in 2014 when NGS came along and we dropped CGH at that point. So some things that are unique about our data set are obviously they're performed by a single physician, me, which means that we've eliminated some of the bias in the data. We have seen with groups that I've been in the past and with other physicians that there can be considerable variation in the stimulation protocols, if not the stimulation philosophies that several physicians have. And the same can be said for the frozen embryo transfer protocols that we use. So there was consistency in ours. And I think most of the embryologists in the room who have observed embryo transfer, and probably some of the physicians as well, realize that there's considerable difference in the embryo transfer technique itself. I think this is sometimes underemphasized. You can take a perfectly normal euploid embryo, and if it doesn't end up in the right spot, it's not going to implant. So we had consistency with that as well. We use a transvaginal ultrasound-guided technique that I described back in 2000. We have a fairly liberal inclusion scheme for our patients. They have to have at least 3 follicles on day 3. We do evaluate all patients on day 3. I don't pre-treat with birth control pills or anything like that. And they have to have an FSH level under 15. The only exception to this is when Simon sends me a patient, like he did recently, who never has an FSH level under 20 and assured me that she does well even though that was the case. We took her on, and I can tell you, Simon, that she did at the end of the day, after 27 days of stimulation, ended up with a euploid embryo. She's currently stimulating again because that wasn't enough, and hopefully we'll have another one to add to the group. So in the process of performing PGTA on so many patients, we've actually changed the way that we manage them. I have, especially because of the emphasis on frozen embryo transfer, concentrated much more on the stimulation protocol. We're taking out a little bit longer. We're more aggressive in the way that we stimulate. And so to this end, we primarily use a GnRH antagonist protocol, FLAIR protocol. Again, we don't batch patients or use birth control pre-treatment because in some patients it definitely suppresses the number of follicles that are available. And then the stimulation is more aggressive in the sense that we take it out maybe 2 or 3 more days than we used to. We now like to grow the follicles a little bit bigger, 20 millimeters. And the concentration here is to obtain as many mature oocytes as we can, because the more mature oocytes, the more eventual embryos we'll have available to biopsy. To mitigate the risk of OHSS, we do make liberal use of cabergoline. And then on the frozen embryo transfer side, we've always used hormone replacement, kind of settled in on intramuscular estrogen and intramuscular progesterone. I've never used vaginal progesterone because I think the results are too variable. We have experimented with oral estrogen, skin patches, vaginal estrogen, but I think the most reliable way to do it is by the intramuscular route. All the transfers are performed after 5 days of progesterone unless we have some evidence from an ERA cycle that more days would be better. And again, we use the transvaginal ultrasound-guided approach. In the laboratory, we see a pretty high rate of oocyte maturity as a result of our stimulation regimens. So we get about just over 82% of the embryos are mature. We perform ICSI on all of them, which gives us a fertilization rate of around 75%. All the embryos are laser-assisted hatched on day 3 in preparation for biopsy, and then whenever the biopsies are expanded enough to technically do it, either day 5 or 6 or 7, the biopsies are performed. We use an aseptic closed vitrification method in our laboratory for all embryos. When it comes time to thaw and transfer them, they're thawed and transferred after a few hours, and we rarely see embryos that don't survive this. In fact, I don't remember the last time we had an embryo that didn't survive. Early on, we did a validation study, and as a part of this, we compared patients whose first transfers either had or had not PGTA performed, and we compared their implantation rates as well as their live birth rates from an intention to treat perspective. And what we found in the patients that had PGTA, you can see in blue, the average implantation rate was about 80%, where the patients who didn't have PGTA had an average implantation rate of about 20%. And obviously the PGTA patients performed better in all age groups. This is also reflected in the intention to treat live birth rates, where again in blue, the patients with PGTA significantly did better than the patients that did not. So as a result of this, we found that there was a 97% increase in the take-home baby rate in the patients who used PGTA, and that the implantation rates really held up across all age groups. Additionally, we found a statistically lower spontaneous loss rate, 4.4% with the PGTA group versus 12.9% for those that did not have PGTA. And so we were able to conclude from this that when we used PGTA in a frozen embryo transfer for all patients, that we were able to increase the pregnancy rates per first transfer in patients under the age of 43. We significantly increased the implantation rates across the board in all age groups, which allowed us to transfer fewer embryos. And this really was what gave us support for moving to routinely transferring single embryos. We also did a concordance study to make sure that we could reproduce what we were doing. And so we rebiopsied some aneuploid embryos. We took both trophectoderm and inner cell mass samples and then sent them blinded to 2 independent laboratories. And what we found here with the ICM biopsies were 100% concordant for the original aneuploidy, and the trophectoderm biopsies were 97% concordant, so we felt pretty good about that. Interestingly, we found that 30% of the trophectoderm biopsies had mosaicism, and we noticed that they all came from biopsies that were, quote, difficult. And I'll have a little bit more to say about that when we talk about mosaicism at the end. So let's look at some outcomes. First of all, lest you think that we treat only Southern California surfer girls, that's hardly the case. As you can see, our average age patient's 37, median age is 38. In fact, almost 3/4 of our patients are over 35, and over half are over 38. At the bottom of the slide, I've notated the average number of oocytes retrieved. You can see in what I'll call the younger group, which is under 38, they had nearly 14 oocytes retrieved per cycle. The older group, nearly 12. This led to a number of 2PN, just under 9 in the younger group and about 7 in the older, and resulted in about 5 blastocysts per cycle in the younger ones and just under 4 in the older group. So this data set that we're going to be talking about then went from 2012 to August of 2018. There was approximately 1,500 embryo transfers performed during that time period. Over 7,500 embryos were biopsied. An overall euploidy rate of just under 50%, overall implantation rate of about 75%, and the spontaneous loss rate averaged out at 7.5%. There have been over 1,000 babies born. This is a slide that I show all of my new patients on their first visit. I think it gives them a very good idea about where they stand, given their ages and the effects that age have on fertility. So what I tell them is it shows about the percentage of what I would call normal eggs for various age groups. Really, it's the percentage of mature oocytes that we retrieved that turned into euploid embryos. And I think the only surprising part about this was that our egg donor group, which are very young, obviously, had less than 40% of their oocytes that became euploid embryos, which is lower than I would have expected. And the other ones, you see up to age 43 plus. We really don't, I should have said 43 to 44, because we've never had a euploid embryo in a 45-year-old or older, even though we've had several women who have volunteered to be the first one, so I wouldn't have to say that anymore, but we still haven't found that person. I know others have, but we haven't in our lab. This is the percentage of the blastocysts that we biopsied that were in fact euploid. And here the donors really did show their stuff. Nearly 2/3 of their embryos that were biopsied became euploid. And then we saw the expected age-related decline from that point on. And this is the cycle analysis. Interestingly, in the blue, I'm showing you the percentage of the cycles in the various age groups where we had at least one blastocyst to biopsy. In the donor group, every single time we have one. And interestingly, even in the 43 and 44-year-olds, almost 80% of the time we have a blastocyst to biopsy. So while that's encouraging, if you look at the green, you'll see that there's a significant drop-off with age in the cycles that actually produce a euploid embryo. But still, the 43 and 44-year-olds, nearly a quarter of them will end up with a euploid embryo at the end of the day. Here's the implantation rates across age groups that I referred to earlier. It averages out at about 75%. We really can't demonstrate any significant difference between any of the age groups in terms of the embryo implantation rate. And this also applies to the live birth rates per transfer across age groups, although it looks like there may be some differences when you analyze it. There really aren't. So what I take from this is, as long as we have a euploid embryo, it doesn't really matter how old the patient is. They have the same chance of it working, and we think the chances are excellent. So if you want to look at this from an intention to treat standpoint, and I'll remind you that that means that we include as a negative result every cycle that's canceled, every cycle where we don't have an embryo to biopsy, every cycle where we don't have a euploid embryo after biopsy, and everyone with a negative pregnancy outcome, if we count all of those as negatives. I have a slide similar to Alan's where we compare our data to that of the national most recently published SART data. And we significantly outperform them in all age groups. This isn't exactly an apples to apples comparison because in the SART group in the US, still probably only about a third of the cycles are single embryo transfer. So this includes multiple embryo transfer cycles as well on the national level. So what have we learned from this data? Well, several important things. This is what I told you I was referring to in the early days when we were looking at the fresh versus frozen. You can see, especially in the younger patients, there was a dramatic increase in pregnancy rates when we looked at the patients who'd had frozen embryos versus fresh. I suspect it was more dramatic there because they had larger number of oocytes, higher estrogen levels, so it advanced the endometrium more than in the older patients who maybe had fewer, but it was still enough for us to move on. If you concentrate on the euploid part of this is as expected, and others have shown the same thing. As you move from a Gardner score A, B, and to C in both ICM and trophectoderm, you see a decrease in the percentage of those embryos that are euploid as you would expect. And here, I'm going to take a minute to look at this slide. We took a look at the percentage of the embryos with various Gardner scores and how many of them actually turned out to be euploid. One of the most important things to look at is our top quality embryos. So if you look at the AA embryos, what you see is that nearly 40% of those embryos, the ones that we would all agree are the best ones and the ones we should transfer, are in fact aneuploid. So for a program like mine, if we're doing simply single embryo transfer and we're using morphology alone to make embryo selection, we're going to be wrong 40% of the time. On the other end of it, if you look down towards the poorer quality scores, there's still a significant percentage of them that are in fact euploid. So if you got a patient with 2 embryos, one is AA and you've got another one that's BB, and you obviously, if you didn't have PGTA results, you'd transfer back the A embryo. If that one ended up being aneuploid and the other one was euploid, you'd be wrong again. So although these scores are helpful, they're by no means definitive. This is reflected somewhat in the implantation data. The take-home message from this, if you concentrate on the first really 4 boxes except for the AC, because the other ones have small numbers, you see that we really didn't demonstrate, except for between the AA and the AB embryos, a whole lot of difference in implantation rates. So I use this to counsel my patients who are still concerned about morphology scores and ask me about them all the time, that as long as we know the embryo is euploid, the score probably doesn't matter so much in every case. Although the embryologists, I think, still select the ones with the best morphology to transfer, but it doesn't necessarily need to be so. If you look at the day that the embryos are biopsied, you find pretty much, I guess, what you'd expect. The day 5 and day 6 embryos have significantly higher implantation rates and significant lower spontaneous loss rates than the day 7 embryos do. But initially we weren't really working with day 7 embryos, and we started to focus on trying to look at more of those as time went on. And although the numbers aren't nearly as good, they're still not bad for those patients who only have a day 7 embryo to transfer. So in summary, what we've learned, I think, is that the frozen embryo transfers do improve outcomes. They certainly allow us to biopsy all the embryos, not just the ones on day 5, so the patients have a lot better chance of having a euploid embryo to transfer when the time comes. And again, the frozen embryo transfer process allows us to really focus on stimulation to increase the number of embryos that we have available. Again, morphology may be helpful. It's somewhat predictive, but not definitive in terms of determining which embryos are the best ones to transfer. And again, the euploidy is the ultimate determinant of whether an embryo is able to implant. We don't see much in differences between day 5 and day 6 embryos, and obviously we'll choose those over a day 7 embryo whenever we can. A couple words about mosaicism. I think I'll leave most of this discussion to those who have more to say about it later. In our program, we report mosaicism as either low if it's 30 to 50% or high if it's 50 to 75%. And we have an overall occurrence of about 8% over this time period, equally distributed, pretty close between the lows and the highs. And about half of these are segmental mosaics. I took a pretty conservative approach to this early on because not much was known about mosaics. I didn't feel very bold at the time. So what we did was re-biopsied those low-level mosaics whenever that's all the patient had. And we found in the ones that we did, about a little over half turned out to be euploid. We've transferred 4 of those, and those resulted in 3 live births. I think over time, now that there's more data, I'm becoming a little bit more liberal in the consideration to transfer some of these mosaic embryos. And with aggressive genetic counseling, I think our patients are able to take advantage of it if they wish. Now, one thing that our embryologist, especially John Whitney, recognized as we were going through this is that there did seem to be some indication that the biopsy technique might have something to do with this. And so we looked at the difference between what we called ideal biopsies compared to what we called difficult biopsies to see if there was a difference. Difficult biopsies were defined as those where they needed to use either more than 10 laser pulses or if they observed significant cell lysis. And when we did that, we found that there was a higher rate of aneuploidy in those difficult biopsied embryos than there was in the ideal biopsied embryos. In this data set, we included the mosaics in the difficult group. And this led us to ask the question, can the biopsy technique actually cause mosaicism? So we performed another study where we intentionally performed these difficult biopsies, and we used both aneuploid and euploid embryos for this. We had 17 embryos enrolled. There were 53 trophectoderm samples, 13 ICM samples. 21 of the samples were difficult, 32 were ideal. And in the difficult group, nearly a third of them showed this induced mosaicism. Whereas in the control biopsies, the ideal biopsies, there was none. Additionally, all the ideal biopsies that came from the same embryos that had that induced mosaicism had no mosaicism. So we believe that there is something perhaps to this. So what have we learned in the application of PGTA in all cycles? It's certainly, I'm not advocating that this is for everybody. As we've noted in the STAR trial, for instance, when we looked at the data, I was on the committee that looked at that raw data, and there were some centers that did really well with PGTA, some that didn't do well. My opinion on this is it's such a laboratory-intensive procedure that so many things, as Alan mentioned, have to be perfect. The embryo culturing, the biopsy, the freezing, that you really have to be able to do all these things to do it well. So I'm not advocating that this is an approach that every IVF laboratory should take. But we've noted pretty consistent now over the 6 years we've been doing this, year-over-year consistency in both implantation and live birth rates. And so we feel that in the right setting, it does have good merit. Some take-home messages from this, I think, are that we showed that we could improve take-home baby rates in all age groups, really when we analyzed it by intention to treat in the performance of PGTA. That even the transfer of some of what we would have called fair or poor quality embryos when we base it on morphology alone didn't really decrease the pregnancy rates. And now by allowing more embryos to get to day 7, we're giving even more patients the opportunity to have an embryo to transfer. Our mosaicism rate has dropped now from 10% to down to about 5% since we've really concentrated on standardizing the biopsy technique. And I'd be remiss if I didn't commend my laboratory staff. These are the people that really make it happen. They're an exceptional group led by Mitch Shuey, and I give them all the credit, also all the blame when it doesn't work. So at this point, I thank you for attention again. Thank you for the invitation. I'd be happy to entertain any questions you might have.